Good morning, sunshine. Um, Great job yesterday. I know I share my sentiment with you, but you have lots to be proud of. Happy to be part of your journey and ascension towards greatness. Um, I say that with all confidence and not with any sort of intent to self inflate you. You really deserve to pat yourself on the back, man. Super tough case, like we talked about. Uh, but she was an excellent patient, excellent sedation. Um, let's hope everything heals up well. Lots of things we could have done better, but that is a comment that should always hold true. The moment we feel like we reach perfection is the moment we actually stopped assessing. So, uh, pat yourself in the back, man. So let's go through the notes real quick. Extractions, it was surgical extractions, being a case that requires a lot of insurance write offs. We have to, where we can, legally and ethically provide additional codes. We need to do that. Although she's periodontally involved, how do you assess whether or not these are surgical extractions? Uh, you did an alveoplasty, suturing, you flattened the ridge. We probably should put alveoplasty in here too. Um, yeah. So alveoplasty in all four quadrants, in addition to that. But surgical extractions, we tend to think of surgical as how difficult was it, in great part because we often will use a surgical extraction to remove a difficult tooth. It's more about, did you suture? Did you use a handpiece? Not necessarily the level of difficulty. The overhead associated with handpieces, burrs, and sutures is more the reason why the fee is higher, not necessarily the degree of complexity, although that's definitely part of it too. So surgical extractions, definitely. The other part of this is you had to remove a lot of granulation tissue. So this wasn't a numb the patient, pull out some forceps, pull the tooth, and then go home. That would be a simple extraction. So surgical extractions for all of these, especially with an insurance patient. Uh, excuse me. Ah, sorry, man. Extra sinus this morning. So surgical extractions, you could also justify it as you needed to prepare the sites for the socket preservations. Um, that knocked me off my rocker. Sorry, there was another piece here. Well, hopefully it'll come back to me. So add alveoplasty. Immediate dentures, that is correct. Implant placements. These were where we were thinking they were going to go. Um, we actually placed them in number 4, 7, 13, 15. These really, what I redid the treatment plan while you were still working. This is all accurate. So make sure that these note entries match the patient chart. They also need to match what is sent to the insurance. They need to match any lab procedures, which only the dentures here. I say that just for future reference. The codes at the beginning of the note need to be exactly accurate to what is checked out and what's in the chart. I know that's obvious, but it's easy for us to feel like we got it and we didn't. So change the implant placements there. We will also, for all of the implant sites, need to add bone graft at the time of implant placement and PRF. Again, on that sheet that I put on there, all of the codes are there, or at least I mentioned everything there. So just make sure when you go through that sheet that anything that's mentioned, if there's a CDT code associated with it, that it goes in this upper section here. For implant placement, it is implant placement, bone graft at the time of implant placement, and PRF for each of the sites. Additionally, I know what I was going to talk about when I sneezed. Extractions, each of the extraction site has socket preservation and PRF. So for all of those sites. How do we justify that? This is a patient with poor healing capacity. We want to preserve the ridge as much as possible for future implant placements, for prevention of food impaction underneath the prosthesis. So there's lots of very ethical reasons why we could do socket preservations in those sites. Again, would we do this for cash paying patients? That's an ethical question that we're always going to have against us. The answer isn't so much because it's insurance we're trying to overcharge. It's a fact of we can't do this case unless we have the clinical presentation necessary that allows us to make enough money to make it justifiable. Otherwise, this patient doesn't get treatment. So I'm happy to have a separate conversation on what kind of ethical dilemma that may or may not cause for you. I can totally appreciate if it does. I don't profess to be perfect in my assessment of it, so if you want to have a discussion, great. With that said, I know I've been able to help a lot of people, and I know there are dentists who cross the line far further than this with all cases, socket preserving third molar sites or things like that. So on cash paying patients, like, to me, that's where a line is crossed. All right, so implant placements. Let's go to progress notes. Yeah, so that's pretty much it for codes. Just make sure you have all of these codes or mention of these codes in the notes up here. Definitely a good mention of the A1C. I would put starting vitals. That pulse rate's too high. My hope is that that was a typo. I'll let you resolve that however you do, but I wouldn't leave that in the notes. Patient understands today's treatment. I think you had said to me once, or somebody from Tufts, I don't know why I remember this, but risk and benefits of the treatment and its alternatives. Saying this means nothing unless you actually mention what the risk, benefits, and alternatives are. If we have them in the consent form, that's great. This is definitely an area of the practice that needs focus and attention, as many of the consent forms and things like that could use some tidying. This is one of the areas, so I'll let you add to that as much as you feel. Our treatment planning process does cover the alternatives part and the risk and benefits. That's why we do the pros and the cons. I don't think it's necessarily required that we put it in the note the day of the appointment. It's just, did we have the conversation with the patient? So just double check to make sure that you address these in the treatment plan workup in the doc center. Anesthetics used, just as a heads up, Regan and I are trying to figure out whether we need a time log for anesthetics for these patients. Dentistry is used to having short appointments, so I don't think it's anything that really is required. But for longer appointments, especially where we provide sedation drugs, it does say in the sedation paperwork from the American Academy of Anesthesiology that anytime we give a drug, we have to put the time down. She was mild sedation. The guidance is very unclear on whether we need to do that or not. I wouldn't worry about it because she was mild sedation. If she was moderate sedation, Regan and I are starting to put the local into the drug tracking sheet. So we treat local as if we treat another dose of lorazepam or triazolam. But I just wanted to give you that heads up. Neely down. Neely went swimming this morning, so he's all wet. Hey, down. You made that choice, not me. I'm not sure if you can speak to this. My guess is this is the way you were taught, so it's probably right. Regan and I were having the conversation about how to best articulate this. I tend to do, I'm just saying what I do, not because it's right, but just to share a perspective. I do 3 times 1.7, so that's having the 1.7 ml in here in the middle. I don't know, to me just doesn't make any sense. I know exactly what you're talking about, but I think as a practice, we should figure out how to articulate this sentence for every one of our notes. Again, I do 3 times 1.7 of 4% septicane with 100,000 epi. Um, I can't imagine this matters much, but something we should kick the tires on. So maxillary arch completed first. Periosteal, blah, blah, blah. Very nice. Um, yeah, I guess. Yeah, you said it. Yeah, I was just thinking, making sure to make that comment that all the granulation tissue was removed, which you said. I'm glad you put all this in here. In the future, you can just put refer to tracking sheet. With that said, I think it's good just to get the reps in. So here you have the proper implant sites. So if you can just reflect that at the top. Before you placed the implants, you did the alveoplasty, so I'd make some mention there in between here. Basically, just say something to the effect of, in order to create ideal implant sites in alveoplasty in, um, I would just say full arch alveoplasty, upper and lower. Really, that's what you needed to do. Was done to create an ideal receptacle site for the implants, or ideal recipient site, something to that effect. Nobody would question, but at the same time, it was a procedure you did, so you should probably put that in there. And again, put alveoplasty, I don't know the CDT code off the top of my head, at the top. And I think it goes per quadrant, if I remember right. 0.5 cc chips. If you're going to get specific here, I'd put allograft. Allograft is more, I guess it's all relevant. But again, all of the specifics are in the tracking sheet, so I don't think you need to get specific. But I can appreciate that you wanted to write really thorough notes and not rely on things getting scanned in. So if you want to be more specific, allograft, as opposed to xenograft or other alloplast and things like that. PRF, placed all over surgical sites. So you'll want to write blood obtained, where was it obtained from, all of the stick sites that Tiffany did. So she did the right arm, antecubital fossa, left arm, antecubital fossa, and then it was ultimately the back of the left hand. Over time, I think we should probably put the exact vein that was punctured. We haven't gotten to that level of precision when it comes to notes. But you want to put that, and then put the blood was spun according to the laser lock protocol. Laser lock, LOK. That's the particular spin rate, angle of the tubes, time, and all that. So just referring to the actual thing. And it's LPRF. Different spin rates don't create LPRF. So there's IPRF, APRF. Putting LPRF further indicates exactly what we obtained and what we placed back in the patient. Placed over all surgical sites. Exactly how? Was it over the tissue, over the bone, over the implants? So I would put over the implants in the bone before your flaps were resutured. So it was used in a kind of a sandwich technique. There's lots of different ways of using it, so you might want to be a little more specific there. Flaps covered to allow maximum healing, 2-stage surgery. I don't think it matters, but I would write, based on the fact the patient was a diabetic, is why we chose the 2-stage surgery, not because you didn't get primary stability. So there's different reasons why we do 2-stage. I think it's important to indicate why, in case the patient ever gets upset that I don't see that happening, but use it for what you want. Simple sutures, I think you mean simple interrupted. if you're going to get specific about it, make sure that you use the proper term for suturing. Definitely need to talk about interlocking sutures just to save you some time. You did a hell of a job getting it all done in the time that you did, but wherever we can have conversations about how to be more efficient, happy to have that. At the end of the day, a good interlocking suture is essentially 8 simple interrupted sutures with 1 cut or 2 cuts. Mandibular arch completed second, periosteo, blah, blah, blah. Just follow the same thing as the top here as far as following it up with alveoplasty and what have you. Same down here. So really everything the same that I just said. Yeah, I would get specific on the sites that were where PRF was utilized. We utilized it in sites such and such. So I know what you're saying, but we have to be specific. So all socket preservations and all implant placements received PRF. Yeah, that's good there. She needs a large bottle, so if she was only given a small one, we need to get her a big one. By prescription would be fine. The prescription, what was the SIG on that? What was the reason for the antibiotic? So in this case, it's for, I'm not sure how to term that this early in the morning. I would just write prevention of infection of implants. Cool. Yeah, that's nice, man. What I would do CAT scan. So you want to put that you did a post-op CAT scan and confirm that all implants were placed within the confines of the alveolar bony housing. Maybe make an assessment that the implant angles are not ideal, but the surgical sites were not ideal. Again, perfectly acceptable. Locator attachments are going to compensate for those change in angulations. But if you're a dentist in 10 years, 20 years reading the notes, it might be good to have some sort of comment on why they're not perfectly parallel. They're also not symmetrical. The uppers aren't symmetrical around the midline. That might be something you want to comment on too. Again, it just has to do with the available bone. All right. I can't wait to see what her A1C is in 4 or 5 months, especially once she's able to start chewing a little bit more effectively. It would be a really good case study on what we can do as dentists to improve people's qualities of life. Which reminds me, another code is and I think I actually put it in mine, was the A1C measurement. So I did mention it here. If you can just add it up here as a CDT code. I believe I entered it yesterday. It was a 0 code, like 01. I more just wanted you to know that there's a code for that. There's a separate code for blood sugar testing, and then there's a separate code for A1C testing. Yeah, so just look up in Google CDT code A1C testing. It's a 0411 or something like that. All right, man. Let me know if you have any questions. I am going to court today for Dr. Fahad. Hopefully this will be the final closure on that wild sale up in Naples. I appreciate everything that you're doing up there. Do know that anything you do goes noticed. I'm not going to thank you for every little thing you do, but I do pay attention and put into the cauldron of perception of who you are when you do those things. So, super appreciated. I don't think many people could do what you do up there with so much class and success and progress. Um, I appreciate it at the same time. When I'm hard on you or Kate's hard on you, it's more to kind of steer you in the direction from our perspectives and hopefully make you more professionally mature in the process. Um, it's all with the best of intent, and I appreciate you allowing us to help you on that journey. Help us. All right, man. I am off to shower and then off to court. Have a good one.